upper extremity with us, and Dr. Bill Ristevski is one of our trauma and upper reconstruction fellow upper extremity reconstruction clinicians, surgeons, and he's an associate professor with our department and runs the undergrad CTU service at the Hamilton General as well, and has very much has a lot of involvement in all kinds of research. And I want to put a warm welcome out to our panel. We have a great group of experts with us on both upper and lower extremity to discuss some of the concepts and the cases. Dr. Julie Adams is joining us all the way from the University of Tennessee, and she previously was at the Mayo Clinic, and she is an upper extremity specifically hand and upper extremity surgeon, and heavily involved in AOS as well as the Hand Society. Dr. Brad Muelenkamp joins us from Ottawa. He's trained at the University of Calgary in trauma and is now and also did foot and ankle fellowship, and he runs trauma and foot and ankle at the Level 1 Trauma Center over at the University of Ottawa. And we have Dr. Buckley joining us from Calgary again, and humbled to have him as a master educator and sharing some cases with us tonight on foot and ankle and his expertise, and as well equally humbled with Dr. Dominique Rouleau joining us from Montreal. Truly an expert in upper extremity and especially with proximal humerus fractures. So it'll be really interesting to have her share her expertise with us tonight. And we'll have our schedule set up with Dr. Rhee presenting a first case, and now we follow Dr. Muelenkamp, who will be joined by Dr. Bill Hayden, one of the residents in Ottawa, presenting a case there. Dr. Buckley also has a case to share with us, and I think potentially Dr. Rouleau has another upper extremity case to share with us. We'll see how time is going, and with that, I do want to turn it over to Dr. Rhee to begin our evening. Perfect. Oh, I think just you're on mute there, Chris.
Can you hear me now?
It's better, yeah.
Okay, perfect. Hi, everyone, and thanks a lot, Dr. Johal, for introduction. My name is Chris Rhee, and I'm currently doing a fellowship in upper extremity and trauma at McMaster. Thanks again for this opportunity to present the case, participate in discussion, and hoping to gain more insights from more experienced senior surgeons. So I'll be presenting a case for a proximal humerus fracture. So this is the 69-year-old gentleman who is right-handed. Other than mild COPD, he's otherwise a very healthy gentleman and also physically very active. He presented himself to the emergency department after he fell off the bike and landed on his right shoulder. Pain was localized to his right shoulder, and there's no open wound, no obvious deformity, and neurovascular exams are unremarkable. He didn't have any other associated injuries. And on the right side of the screen, this is the AP X-ray of his right shoulder. So I'm gonna pick one of the residents. Is Dr. Phil Hichet here?
Yeah, hey, Dr. Rhee.
Yeah, hi. Yeah, so can you describe what you're seeing on this image? And also let me know when you want to see the other views.
Yeah, so we have a single AP of a right shoulder. There's a minimally displaced surgical neck fracture. On this single view, the glenohumeral joint looks congruent, but I want to get multiple views, including a Velpo, to have a better look at it.
And here are the transcapular Y view and the axillary view. Anything you'd like to comment?
Yeah, so overall, looks like a surgical neck fracture, slight apex looks anterior, but otherwise minimally displaced. So in a 69-year-old gentleman, I plan to treat this non-operatively in a cuff and collar, bring him back in a week or two for some repeat radiographs.
Yeah. Good. So exactly. So given that the fracture is minimally displaced, the decision was made to treat this non-operatively. And here are some additional images. So these X-rays are taken at 2 weeks and 6 weeks post-injury, respectively. So Dr. Ishii again, can you describe what you're seeing on these images?
Yeah, so There's been further progression of deformity, so it looks like there's been shortening, and the head's fallen into varus as well. I don't appreciate too much healing, so I want to know how far out he is from the injury.
Yeah, so the left X-ray is 2 weeks after injury, and the right side is 6 weeks.
Yeah, so I'm worried that there's progressive varus angulation at the fracture site. Have a discussion with him. I think at 6 weeks, it's still possible to treat this conservatively. I do think that his long-term shoulder function is not going to be as great with this if it does heal in this amount of varus. But I'd probably follow him along with some repeat radiographs.
Okay, so at that time, a patient wasn't very interested in surgery, so it was continued to be treated non-operatively. And again, the image on the right side shows his X-ray at 3.5 months post-injury. Clinically, he continues to be quite symptomatic with a lot of pain, and is not able to tolerate any forms of physiotherapy. And as you can all see on these X-ray, this is a significant varus alignment, which is not that much different from his previous 6-week post-injury film. And also there is a lack of radiographic healing as well. So at this point, the discussion was made with the patient about the treatment options, and decided to go ahead with the surgery. So getting back to you again, Dr. Rhee, any investigation you would like to order before going ahead with the surgery?
Yeah, I think a CT scan to better assess the bone stock would be helpful, and have a better look at the tuberosities, although they look like they're reasonably intact.
Good. So these are some, these are corona cuts from the CT scan. I'm going to run it a couple of times so we all have a good look at it. And these are the sagittal cuts. And sorry, I hope I can run it slower, but I don't know how to. And then these are the axial cuts. Yeah, so by the time the patient was referred to our hospital, it was around 4 months post-injury. And as you can see on the CT scan, it demonstrated again the varus malalignment at the fracture side with delayed union. So what are the surgical options at this point?
Yeah, so I mean, quickly on the CT scan, so it definitely looks like there's delayed union. Surgical options at this point. You said he's 69?
He's a 69, but very healthy.
Very healthy. So surgical options at this point would be open reduction, internal fixation. But I'd also be prepared with either most likely a hemiarthroplasty I'd want to have available if needed. And if he was a little bit worse off physiologically, I think he's getting on the group that would potentially benefit from a reverse total shoulder arthroplasty as well. But my primary goal would be open reduction, internal fixation.
Right. So at that time, we decided to go ahead with the open reduction and internal fixation, given that he's physiologically young and a physically active patient. He also didn't have any pre-existing shoulder problem. Any challenges you would encounter in the OR for surgical fixation of this kind of injury?
I'd want to have a better look at the CT scan. It did look like there was a bit of a bony void there. I mean, obviously correcting that varus deformity is going to be super important in restoring your medial calcar. So I think the option of having a fibular strut allograft that's a really good adjunct to help restore that medial calcar if you find that there's bone loss there and we can't otherwise restore it. I want to get some sutures into the rotator cuff because it seems like that's what's causing the varus deformity, and that can help reduce that deformity as well.
Yeah. So sorry, go ahead.
I was just going to say, in addition to freshening up the fracture site, debriding any sclerotic ends as well.
Right. So as you rightly mentioned, one of the main problem we thought it would encounter would be the lack of a medial support due to the chronicity of the fracture in a varus malalignment. So there was no good medial calca support shown on both the X-ray and the CT scan. And also because the proximal fragment is in varus for such a long time, the rotator cuff will be quite shortened and contracted for a long time. So this would make it difficult to correct the varus malalignment. So in the OR, we did a standard delta pectoral approach to expose the fracture. After suturing the rotator cuff tendons at its insertion with heavy non-absorbable sutures, we bluntly dissected to release the subacromial space so that we can mobilize the proximal fragment and correct the varus deformity. Then we placed the fibular strut allograft to restore the medial calcar. We preliminarily held it with the K-wire. Then we reduced the fracture and also held it with the K-wire. We checked with the fluoro and we are happy with this preliminary reduction. So we went ahead with the fixation with the proximal humerus locking plate. And then this fixation was supplemented by tying down the sutures, holding the rotator cuff to the plate. And these are some of the intraoperative images. So I'm not sure how well everyone can see, but you can see a fibular strut allograft adding the support for the medial column. So yeah, good job. Thanks a lot, Dr. Rhee. And just want to quickly go through another case of a proximal humerus fracture that the fibular strut allograft was utilized. And this is a patient with a very different demographic, different comorbidities. So this is a 58-year-old gentleman who is quite comorbid. He has a kidney transplant patient due to a complication of his long-standing type 2 diabetes. He also has hypertension, hypothyroidism, and some of the other complications of long-standing diabetes, such as retinopathy. He fell from a standing height and sustained an isolated right shoulder injury. So these are the three views of the patient's right shoulder at his initial presentation. There is a displaced surgical neck fracture. The alignment looks fairly good on the AP view, but the transscapular view and the axillary view show that there is the shaft is anteriorly displaced and there's a apex anterior angulation deformity. So he was initially treated conservatively with a collar and cuff. His follow-up X-ray show a lack of healing, and also he continued to have pain and was not able to do much with his shoulder, even a gentle range of motion. So at 2 months, the decision was made to manage his fracture operatively. So these are the three views of his right shoulder X-ray at around 2 months after the injury. So AP looks deceivingly good in terms of alignment, but still at 2 months, there isn't much of a healing going on. And if you look at the transscapular and axillary view, the initial deformity we saw in these views, that his presentation is worse on these views. So some of the CT images of his shoulder. So these are the coronal cuts. It's gonna run it one more time. And these are the sagittal cuts. And the axial cuts. Okay, so this patient was taken to the OR for open reduction and internal fixation. And due to a severe osteoporosis, decision was made to utilize the fibular strut allograft. And these are some of the intraoperative fluoro shots of the patient's shoulder. And you will notice that the fibular strut allograft was utilized in a slightly different manner compared to the first case. Fibular stud allograft is gaining popularity as an augment for surgical fixation of a proximal humerus fracture, in part in order to address the high complication rates associated with the fixing the proximal humerus fracture, such as screw cutouts and varus collapse. There's some biomechanical studies showing increased load to failure and construct stiffness, and also shows that the motion at the fracture site is reduced when the fibular strut allograft was used in conjunction with the proximal humerus locking plate. It is utilized to provide the medial column support and or fill the large cavitary defect. Most of the studies are either non-comparative case series, but a couple of retrospective comparative studies showed some promising outcomes compared to the standard locking plate alone. The proposed indications across the studies were varus malalignment, lack of medial support, and or severe osteoporosis. So at this time, I'd like to invite the panel for the discussion of surgical options for proximal humerus fracture in terms of when to fix and when to replace, and also discussion on use of the fibular strut allograft or any other adjunct in dealing with the complicated or difficult proximal humerus fracture, and would like to hear some technical pearls you guys use for fixing the challenging fractures.
Great. Thanks, Dr. Rhee, for presenting those two cases. I'm wondering if we could start off with Dr. Rouleau, and two common themes in these cases were that the fracture was fixed kind of like in this late period of 3.5 months or 2.5 months. Can you discuss the intricacies of when you may have operated on these or switched to surgical management, and why?
Thank you. That's a very nice presentation. And first, I can say that the surgery were amazingly well done because it's not easy. Sorry. So always a good timing of a texto just when I'm talking. So my first message is first, the neck fracture, the surgical neck fracture is a very special family of fracture. And regularly you see that when it's not displaced initially, but it can move later. So that's something you see regularly, and it's usually moving in varus. So initially I would not treat it, but it's really something that can happen. Sorry, I have the kids. Oh, so I heard that the Montreal Canadiens had some goals, so that's why we have some excitement here. I'm very sorry. But when you have a case where it's not healing, before talking about surgery, you always have to think about biology. So me, I always look for thyroid problem, vitamin D deficiency, and I know we are surgeons, but it's still for me the first step when I have a patient not healing. So that's really always my first step. About my surgery of choice, then I will make things very differently from you because I revised a few strut graft inside the canal to make an arthroplasty later. And it was one of the worst surgery of my life. So I'm never using that kind of graft personally. In the first case, I would have done an open reduction with iliac crest bone graft and a nail, because the nail is more solid than a plate to prevent recurrence of varus. And also it's less invasive in terms of devascularization. When you do that kind of surgery, it's super important to keep the long head of the bicep, because if you remove the long head of the bicep, you will remove the artery, the Latcha artery. And also it's very important not to go in the circumflex vessel area. So you keep that area safe. So me, that's what I would do. Dectopectoral approach, releasing of the malunion, graft of the iliac crest, reduced of the varus, and a nail. In my experience, I did that a few times. It's not a frequent problem, and I always have success. And in my experience, all these patients, they were always vitamin D deficiency, not just a small deficiency like 32 instead of 75, or smoker, or all of the above. So that's my comment. But I think the surgery was perfectly done, and I mean, I'm sure the patient had a great outcome. it's just a question of choice. It's not that I'm right or whatever, but that would be my preference.
Thanks very much for that. I agree. I would stay away from fibular strut in this particular instance for the same reasons, because they usually land on my lap to do the reconstruction later on. And it's not the same as a femur. Coring that out is really difficult, and maintaining enough hoop stress for your implant after that is difficult. So I tend to agree with that. Dr. Adams, this is deceptively hard fractures because of the delay at like 3.5 months or 2.5 months. It's very surprising how much the humeral shaft will scallop the underside of the humeral head and leave you without any kind of medial calcar. Is there any tips and tricks at this stage that you would use to kind of bring the fragments out of varus? Because that's always one of the trickier parts of the operation.
Yeah, thank you for presenting those cases. Those were great presentations, and I think that these are beautifully done cases and highlight some of the challenges with these cases. Just going back, if I might, to the comment about delay, I think that we certainly see that, and all of us see that in our own offices. And for example, distal radius fractures, we reduce them. We look at the alignment. It looks pretty good. We follow them. The next week, it looks a little less good. The next week, well, it's not so much of a difference. And one of the challenges is I like to pull up the initial post-reduction films and then compare where I am, because sometimes you can be, well, it's not much different, but you realize it's quite a bit different from where it should be or where it started at. And so a lot of the time I will find myself fooled because I'm following the patient, comparing to the prior films when I really want to compare to the ones from the initial management. So that's just a trick I've used in my practice, because otherwise I really get fooled a lot and find that I'm somewhere I don't want to be if I follow further along. To your point, I think that you've outlined that beautifully, and you can see how that shaft has kind of scalloped away the bone. I do like using the fibular strut, but I do have lots of concerns, as you've outlined. If the patient ultimately has to have an arthroplasty, whoever does the arthroplasty will not like you at all when you send them the patient if it fails. So I guess the ultimate result is, if you think that it's going to heal, fine, do it. But if you have some questions, and I'd also like to echo the thoughts about smoking cessation and bone density and vitamin D. People have talked about some fortuitous ways of looking at bone density. If you're getting a CT scan, there's a correlation between the Hounsfield units and the glenoid, and beyond a certain level, you can basically exclude osteoporosis. So to me, that is very, very helpful in my decision-making process. If I say, okay, well, this patient clearly has osteopenia or osteoporosis, I'm very concerned about surgical fixation. Having that additional piece of information, other than me looking at the x-rays and looking at their age and sex and smoking history, and like the second patient with his multiple risk factors, that can be very helpful. In terms of mobilizing the fragment, I think that is a real challenge with these, because as was outlined, you don't necessarily want to devascularize things further. Just as you outlined beautifully in your talk about getting into that kind of subacromial space and mobilizing the tissues, the rotator cuff is contracted. And so you're going to have to bring that down and mobilize the tissues to get to where you need to go. So congratulations on those two great cases.
Just want to ask, and I got to apologize to Bill for putting these reconstructions on his lap when they fail. But a question for Dominique, to kind of highlight the point Rhee just made. If you're doing a nail for this, how are you mobilizing the tendons? Are you still making a fairly open approach to kind of get in there and free those up, or because you're going deltopec to put in graft, you have access already? Or
yes, I do the deltopectoral approach for that, because we need to graft. And anyway, since the URA study, I completely stopped doing any other approach for proximal humerus fracture. And a good trick for a nail in that situation is obviously you make your release as much as we describe. You can also open rotator interval and do some kind of blunt mobilization inside the joint with that approach. And then on fluoroscopy with a Steinen pin, I try to reduce my varus as much as I can. So the pin is in the head. And then I pin the head in the best not varus position as possible in the glenoid. Then after that, I find my entry point. You know, depends of your nail you use. Me, I use a nail where it's coming on the top of the head in the cartilage. So I put my first pin, and then I reduce the humerus by abduction of the humerus to the head. Okay, so my head's not moving anymore. It's reduced as much as I can in terms of creating more valgus. And I abduct the humerus on fluoroscopy, AP and natural, to control my flexion. That's usually an inflection, and the varus. And after, I continue my pin to my guide pin inside the canal of the humerus, and I do my nail in that position. And doing that, at the end, when the nail is solid, obviously the shoulder will go back in normal alignment. And I would definitely here aim to over-reduce in some kind of valgus as much as I can. And I will try to impact the diaphysis in the head as well, because there will be a medial gap. So the medial gap, I will try to impact it.
Self-isolation. Self-isolation.
Sorry about that. Any comments from, I guess, Rick or Brad?
Thanks. I'd just say that this should be prevented by hanging that arm out. And if that patient gets used to leaning on it, because it maybe feels a bit more stable, but this has to be hung out, and then it's got a chance never to go to varus. But once it does, you're kind of stuck.
Yeah, I agree with that. I always tell my patients that have proximal humeral fractures not to rest their elbow on an armrest because that's a killer. They get home on the couch and they put their elbow on the armrest, and it just creates this deformity. So you want to make sure that they don't do that. And we heard about the nail and iliac crest bone graft and plates with the fibular strut. I think if you're really stuck and you don't have access to those types of things like fibular strut graft, one of the techniques would be to pencil the humerus, the distal humerus fragment, and take away some of the lateral wall of the head so you could correct the varus alignment and impact that and basically telescope the two bones together to give you a great bony contact. And that reliably gets you healed and also gives you some calcar support. Now, it'll be a little bit shortened, but with the tuberosities intact, that's really not an issue at all. So that's one of the tricks you can use if you don't have all these fancy strut grafts and you don't want to go to the crest.
Yeah, I agree exactly with what you just said there, Dr. Ristevski. That would be my approach. I've gone away from using the allograft for a lot of the reasons that have been outlined, especially with the late reconstructions and my colleagues being angry with me for using them. And I've not seen a lot of great literature supporting better clinical outcomes other than radiographic outcomes when using them. You can make the x-rays look great, but these patients don't necessarily do better. These are frustrating fractures. I'm actually very happy that I get most of the lower extremity trauma and I can refer on most of these because they're very frustrating patients to follow. I find even if their x-rays look phenomenal, it's a really difficult rehabilitation process. The only other thing I would have added, and it's a bit contrary to Dr. Rouleau, and maybe I should be learning a little bit more from her tonight, being one of the upper extremity experts, but I think it's really important actually to take the biceps tendon because it's such a pain generator. And anytime you go back in for a revision surgery, whether it's a non-union or malunion or revising hardware, that thing is just absolutely caked in the bicipital groove. It's not moving, it's inflamed. And so I routinely take the biceps tendon and do a tenodesis. It's one of the first steps I do when I get in there. And I'm releasing it through the rotator interval and releasing it from the labrum and then taking it for a later repair. And I've been happy with it, but again, I don't do a ton of these, so maybe maybe I should be a bit more careful with these patients.
I think it depends whether you're subpec or at the level of the tuberosity. At the level of the tuberosity, there's less chance that you're going to hurt vascularity. So those are some things to consider. I mean, these are all super points on a difficult fracture or malunion or recent non-union. Depends on how you define it here. But all super points that people have made. And you can see that there's a variety of techniques because there really isn't any one definitive answer that reliably gives patients a better outcome than different approaches.
Would you go to the film before this one? And maybe the film before that? And maybe I think it was the other case. I was just going to make a point. On one of these cases, it looked like initially he had some deltoid, a little bit of deltoid atony, presumably. And just to point that out for the residents, when you're making a decision about what to do with these patients, it's important to assess the function of the axillary nerve, assess the function of the deltoid. A lot of times they'll have a little bit of a deltoid atony which resolves within a few weeks, but being aware of the status of the nerve is important before you operate on him. And this one you can actually see in subsequent films, he recovers.
Perfect. I was just wondering, in the interest of time, if we could move on a little bit. I think with this panel, we could talk about these fractures for an hour in themselves. But I think Dr. Rouleau had a case as well. I was just wondering if she'd like to go through those.
I'm not super good to share screen, so I will work hard on this. Sorry.
Seems like they put the button in a different place each time. I think you should be able to. Let's see.
Okay, here.
Hopefully at the top of your screen, you'll see a button that says share content. Oh, perfect.
Okay, so I start that I have obviously a great conflict of interest, receiving funds for research, and I'm receiving royalty for plates. But you saw I discuss more about nails and plates for now, so it's kind of interesting. So I want to make some comments, and it's really going in line with what was said today, is actually now in the literature and a lot of trauma meetings, we more discuss about conservative treatment because of the complication of the surgery. And it's also all from Profer paper that we know about. And there's a lot of literature going not to fix or treat all these people. But you show exactly two cases where not operating was not necessarily going to go well for a patient. So my question about that, is it science or fashion? And I think it's really a fashion problem. The Profer paper, and I'm sure all of you spoke before about that in your program, it's not a good study. Why? Because they took only 250 patients on 1,050. So you cannot generalize the results to all proximal humerus fracture. It's a study that concerns only patients in the gray zone category. Patient where, is it operate surgery or not? Then, okay, you can apply Profer. But every displacement, significant displacement in young patients, they were all excluded from that paper. So really, again, I want to stick that, and I want to show you some of the Profer victims I'm seeing regularly in Montreal now. So here we have a patient, and actually it's my patient, and you can have my daughter. Okay. Tu veux venir voir mes amis? Yeah? Okay. Sorry about that. So it's my patient, bilateral proximal humerus fracture. I fixed her left side. I think Julien was there assisting me somewhere on the picture. It's late night. It was my first time using my plate. So I was very happy. But I decided to treat the other side conservatively, and it healed well. But the patient, we have a lot of nice Italian people in Montreal, and they are really direct, and they feel great to discuss everything. So she screamed at me, "Why you haven't fixed both sides?" You know, even if the left surgery was kind of the worst, biggest surgery I did in my life, she was saying that, you know, the right side was not as good. So it's my own patient victim. And here is another case. Can you believe? The surgeon decided not to fix that fracture. I mean, the head is looking to the deltoid. Okay, so this is a patient that will be excluded from ProFer. So you cannot apply the ProFer conclusion to her. So obviously she was miserable. So a year later, after a year of pain, I did that to her. Okay, and it's a much bigger surgery when you do that a year later with a patient that is tired and not sleeping for 1 year than initially. Here is another patient. I didn't operate on her yet. She's a 65 years old lady, but working, super active, doing a lot of sport. She had this very simple valgus impacted fracture more than a year ago. Not difficult to fix, but the doctor said, literature now said that your results will be as well if I'm operating you or not. So my comments to resident is read carefully the literature, don't generalize the results, and continue to use the guidelines when you have, like her, she's having 2 centimeter displacement of her greater porosity, according to the humeral head. This will never go well. So if you decide to not do surgery, you have to tell the patient that this will be your maximum. 90 degree of elevation, 0 degree of rotation. And that's the maximum you can get, and you will have pain every night for the rest of your life. Okay, so that's my practice. And that was my comment for you.
But just before you move on, Dominique, I have spent 35 years in my career helping to establish that trauma is a specialty. And proximal humeral fractures fit into that. And we have to have difficult decisions around difficult fractures handled by people who make these difficult decisions all day long. This is not a simple fracture problem. And I think this is the essence of the proximal humerus. When it's a simple problem, a non-displaced neck fracture, it should be treated non-operatively. But when you have a difficult problem, like each one of the ones that you showed, it needs to have a fracture surgeon who has all the tools in their tool bag. And this is the issue where we don't have patients handled appropriately in the right facility, right doctor, right time, with the right operation. So that's my soapbox, but it's obvious to me.
Just to kind of ask about that soapbox, Dr. Buckley, and maybe in time to something we discussed earlier, like what do you think the role of non-op versus op trials kind of falls into that? Because, you know, sometimes that might empower someone who might not just feel comfortable with that operation, try and give them some excuse to potentially treat something non-operatively when it maybe should be operative, and it's just the lack of recognition of that being a fracture that shouldn't apply to.
Well, Herman, I'm so convinced that we need good science, but I'm also so convinced that we even should be more aggressive with our trials and have more institutions with more surgeons involved in even bigger trials. And what that would do is pretty soon you don't have anybody except the community surgeon. And then, you know, the level of care, the level of importance of these fractures rises up, and everybody is more aware that we have to be careful with these fractures. I just think we're still a little bit lackadaisical with treating them, because like Dominique says, you end up with terrible problems over the long term without right decisions made at the right time at the beginning.
And I have to say that I'm a feminist. That's my other disclosure. And I see a lot of ladies, 60, 65, little bit overweight, and people think that they do nothing in their life just because they don't look like an athlete, you know, but that's not true. I mean, they can be super active. They can make a lot of things around the house. They need their shoulder, even if they look a little bit older. It's not like an athlete or whatever, but these people can be very active. So that's super important to ask the patient, what do you like to do? Because in a sedentary person who just look at TV and have no expectation and is afraid of surgery and things like that, you can still do conservative treatment when there's still an indication with the displacement. But I see regularly women, and it's a women fracture, the proximal humerus fracture is female problem. And I think some people judge them very quickly, saying, oh, she's 65, a little bit overweight, she's doing nothing. So, and I think that it's a judgment that we cannot do just by looking at someone. We need to discuss a little bit more.
Great. Yeah, it's a really confusing topic. What I've learned is I don't know very much about proximal humerus fractures after years and years of trying to treat them. Like I have a picture that I'm looking at on my phone, and I know it's not going to show up potentially very well, but I'll just flash it up there if you guys can see that. There's a definitive double bubble sign there because it's a head split that's about 1.5 centimeters displaced, but she didn't want surgery. And then that's her, raising her arm, better than a hemiarthroplasty or anything with no pain, no clunk, no nothing. And I was told my whole life that head splits are an absolute must, that you operate on them and stuff. And then she walks in and I'm just like, I don't know anything about proximal humerus fractures. You know what I mean? Because you can get a person like that, and then you could get a person that's completely debilitated by that fracture. So I think we need some research to hone in on who is going to ultimately end up in that position of good versus bad with this crazy joint that's the most flexible diarthrodial joint, that every little scar tissue influences range of motion. And the center of rotation is so critical that if we switch out a reverse for a regular arthroplasty, we could completely defunction a rotator cuff almost. It's just a very unique joint. It has problems, and I think it's one of the toughest joints to get anatomic reductions on when the tuberosities are blown out. So
but I'm sure everybody here, though, Bill, would agree that we want to have one operation.
Yes.
We don't want two.
Yeah,
and that's absolutely. Why at the beginning we have to make the right choice, right surgeon. And that's the key, is that we don't want two operations, one that fails and on to a second.
Absolutely. Absolutely. Again, in the interest of time, I'm just wondering if we should move on.
I was going to say that sounds like an excellent point to kind of switch to a calc fracture case that might actually highlight some of that.
Okay, so I'll go about sharing my screen here. Can you see that one now?
Yep, that's coming through.
Good. Okay, so on that vein, because this is what I teach and have taught forever, is that there's the patient, there's the limb, and then there's the fracture. And so here's your patient, and I want everybody to be thinking about that. He fell 6 feet onto hard ground. It's now day 5, because sometimes it takes a while for these calcaneal fractures to come into your clinic. He's healthy, no diabetes, no steroids. Blood pressure is his only medication. He's had hernia surgery in the past. He's a non-smoker, manager, meaning that he's his own businessman. This is not workers' comp. He's married with kids, plays a lot of hockey. So you've got the things you need now to make a decision based on this patient. When you now look, and he's compliant, that's really key, is that he'll do what you say. He's a good patient. Now, when you look at the limb, the things here that are going to be significant are he's never injured his foot before, no other injuries, pulses are good, no nerve injury, skin condition is satisfactory, no blisters, and you can do whatever you want to this foot. So you can make whatever decisions you want. And there's only 4. And those 4 decisions are, you can do nothing. Non-operative care works for the calcaneus. You can do a full meal deal, extended open approach. You can do a minimally invasive reduction. Don't forget the reduction, minimally invasive reduction with percutaneous fixation. Chad Coles talked about that last week, but I'm going to emphasize the reduction. If you're going to do a percutaneous, you'll have to reduce it. And then lastly, you can fuse the foot. So here's your CT images, some axials, and you'll see that he's a bit broad. This is more than a Sanders 2. It stretches down into the calcaneal cuboid joint, if you're of the opinion that matters. Here's his images in the coronal plane. Again, at least 3 different parts. He's got quite a large sustentacular piece. You'll note that he is, with his sustentaculum, that piece is a little bit into varus, but the rest of the calc, as is often the case, is into valgus. And so this unilateral statement that's made, oh, all the calcs go into varus, that's a bunch of hoo-ha. It's not correct. Here's the sagittal view. You'll see it's a tongue type, and so it splits out the back. He's quite flat. It extends quite distally, and you can see right down into the calcaneal cuboid joint. Here's a 3D CT. I don't have videos of it, but you can see how it's impacted. His Bowler's angle is quite flat. And here from the medial side, you can see the sustentaculum. And what this is showing is that the medial sustentacular piece, or quotes, the constant piece, end of quotes, is not so constant because it's relatively in place in relation to the talus, but the talus is displaced in relation to the calcaneus. And so what that means is that you don't only, if you're going to do something with this, you don't only have to fix all of the calcaneus to that quotes constant piece, but when you are doing that, you have to fight the talus and fight the Achilles to get all of that reduced in relation to it. So you need to think about how you're going to proceed with that. Now, there's a special program that we used in Davos when we've used this as a teaching case. And you can take each little piece of this calcaneus, and there's about 12 of them, and give them a different color so that when you look at it, you can see how the calc is short in length. And with surgery on the right, you can see if you were to put it together, it's restored. The length is back. Here you can see when the height is short, the height is restored with reconstruction. Okay, now here it is from the posterior view. You can see how broad it is. And if you were to operate on it, how you narrow it. But you'll also note that constant piece. Look at that brown piece on the medial side. It isn't so constant. You're going to have to do your reconstruction in relation to that piece. And so build that calcaneus to that constant piece. So be thinking about it. How am I going to do that? And then the lateral wall so that it's placed back in a better position. Now here you are from the medial side, and look how that medial side piece has been pushed aside, pushed out, the whole heel broadened, but the heel's also shortened, and the calcaneal cuboid joint, its relation to the sustentaculum is off. So the joint is tipped, the subtalar joint. And if you were to do surgery on the right side, you have to fix that. And the joint is widened, and you have to narrow it. Now, the last view is this one. Now, this is from the top. So think about it now. You're looking straight down with the talus removed onto the joint. And on the left side, you can see it's got the 3 pieces, the sustentacular piece, the purple piece in the middle, and then the light blue aqua piece. And now on the right side, it's all reconstructed. But look at that change in position of the sustentacular piece. So if you have a poor joint reduction and it's really wide, should you be looking at reducing and fixing this? So here's your case. And I'd love to hear a surgical plan from one of the residents or fellows. First off, does it need surgery? Secondly, what your approach would be, because there's only 4. You do nothing, you fuse it, you do a minimally invasive reduction with percutaneous fixation, or you do a full meal deal on it. If you are to do a reduction maneuver, how are you going to maintain it? And what are you going to use for your fixation? And then I'll show you what I've done. So Bill, you take me where you want me to go with it.
Yeah, absolutely. I think one of the residents kind of going through that would be fantastic.
You go ahead, you name somebody and they can start answering.
All right, let's see here.
Somebody 4 or 5, I would think.
There's a lot of people on here that Herm, do you see someone that would be able to take it as well? I'm just looking at.
Well, I think, even one of our fellows and one of our foot and ankle fellows, like Anthony.
Absolutely.
Anthony, you with us?
Yeah, I'm here.
So let's start hearing your thoughts.
Well, thank you, Dr. Buckley, for presenting it. One of the foot and ankle, I did my fellowship in Vancouver, and then I'm doing a trauma fellowship, an arthroplasty fellowship here at McMaster. So I've seen both sides here. So going back to your first question, do you mind just bringing up your first question there that you had on your slide?
Yeah, well, I'm showing the pictures because that's what you're going to have to work on, but does it need surgery is your first question.
Yeah, so that's a good question. So it's important to understand whether or not the patient understands the outcomes at 1 year, 2 years, 5 years down the road before deciding what you need in terms of.
So that's a lot of talk, but let's hear it now. He's 50. I showed you what he's about. He's a perfectly healthy business manager, and he plays hockey.
So, like I said, if you're going to talk to a patient about operative management, I think it's important to talk about both, but I'm more inclined to go with operative management here.
Okay, but why? Why would a 50-year-old who's an active business manager deserve surgery for his foot? What does the literature show?
So for me, my understanding with the literature, looking at a Sanders 3 or plus, that the outcomes of operative management initially, you may have better outcomes in terms of pain at 1 year, but at 2 years, there's no difference between non-operative versus operative.
Okay, so if I was to look, and this is where I've got my patient information up here because I think it's crucial, is that he has the opportunity for you to do whatever you want to his foot. Some people you don't, and you can't treat them non-operatively just based on that.
Right.
He has, with his limb, you could do most anything based on the limb. And because he's got a flat bolus, he's got a much higher chance of needing further surgery in the future. And because his foot shape is not good and he's still playing hockey, then he should be an operative candidate. So I think, and Brad, I'll ask you, you wouldn't treat this guy non-operatively, would you?
No, this is an operative case in my hands, and almost all of them are at this point, unless they're truly undisplaced, minimally displaced, or non-compliant. Those are really the absolute contraindications for me is the non-compliance. But otherwise, I think most of these patients that are demonstrating any aspect of displacement do better with surgery.
Okay, good. So
the ability to protect it.
So then, if I ask our fellow, is he a fusion candidate because he's a Sanders 3?
No, I don't typically go with fusions for patients with acute traumas. I usually wait on that. I usually
well, again, the literature is pretty clear. When you've got a really badly smashed foot and a Sanders 4, fusion or operative care, it makes no difference. And so that's my only question. Does he deserve it? And the answer is no. Based on a Sanders 3, healthy guy, you'd like to reconstruct it to give him the best chance. But just because you don't do it doesn't mean the literature doesn't say you should. And if I have a Sanders 4, I fuse virtually all of them. And so, okay, now my next question then comes down, Anthony. If you've got this particular case, you've now got some options. You can proceed with an approach which is open, minimal, or open maximal. How are you going to reduce it and then maintain it? And what fixation are you going to use?
So I do a little combination of both here. So I'm going to do a sinus tarsi approach, but I'm also going to use percutaneous pins to help for my reduction. So initially I would use the percutaneous pins, one to go across to the constant fragment, which you alluded to that isn't very constant, reduce that fragment, and then be able to get the heel out of varus and get it out to length. First with one pin going from the superior anterior aspect of the calcaneus and the other one going across from lateral to medial. And then doing the sinus tarsi approach to open up, decompress the perineals, and be able to reduce that fragment that I've already done with the percutaneous and use potentially something more of a buttress plate to bring up and then build.
Okay, so instead of at 5 days, he's presenting at 3 weeks. Can you do all that?
3 weeks is challenging. Once you get to 3 weeks, it's very, very challenging to maneuver those pieces.
Yeah, good. So you'd have to do this fully open at 3 weeks, but at 5 days, you could do whatever you wanted, and that's the key. Now, as far as time, Bill, should I keep moving along then?
Sounds good.
Okay, so what I should do here is actually show what we did, and this is a case of a heel that I did.
Small incision, right subfibular. The Howarth elevator is in, and it's fully deep right inside the foot, right over to the medial side. Okay, so here we are now, and we've got that small incision, right subfibular. The Howarth elevator is in, and it's fully deep right inside the foot, right over.
Now, I'm showing that because that's the only incision, and this isn't a sinus tarsi approach. This is an approach that I'm using that is below the fracture fragments. And here's my X-ray or intraoperative fluoro showing what I've done on the image with that laminar spreader.
And here we have that first K-wire going in. So you can see again the lovely reduction at the back, our K-wire coming in, and these are threaded wires coming in subchondral. Our crucial angle is reduced, large void still there. And I'm just going to show what that looks like over here now, where we've got the thrill going in, threaded K-wire in place. We have to make sure as we're putting in our K-wires that we stay just posterior to our laminar spreader, and eventually we'll be able to take them out. We like about.
Now, you can only do that with these early ones. And this is one that, having done so many heel bones in my life, and not to brag, but it's up over 2,000 of them now. When you're dealing with calcaneal fractures, if you don't get at them early, you have to do them a full meal deal. But this was one that I was confident I could simply get in underneath. And despite the fact I filled the void, you can see that big void here, and we're at 10 weeks now with this image. These pins are in underneath. We've helped Bowler's angle. It's not perfect, but the crucial angle of Duchenne right here is pretty good. And now I'm just going to show you his result here, because this is the key. If you don't have this, you can't say we've done our job.
And my patient is just going to show his motion. So up and down with your motion. Good. All the way up and all the way down. I'm just going to come from the side here, all the way up and all the way down. Very good. Now I'm just going to ask for those big circles with both feet now. Excellent. Very, very good. Okay, I'm just going to get a good picture of the undersurface of that foot where those pins were. You can't see them. And then the side here where that little wound was. And there it is there. This is at 6 months. Very good. And now if you can just stand up for me, I'm just going to get you to walk both away from me over to the door. Fantastic. Now, can you come back towards me now on your tippy toes, way up high? Good. And at 6 months, super. Now, I want you to walk away from me on your heels. Good. Super. And now I just want you to come towards me. Hold on to the side here and do a deep squat for me. Good. Now, all the way down to a deep squat. Super. And up. That's fantastic.
So, in summary, because I'll finish here and we can talk about it, this is one that we want to minimize our complications. I've operated on so many with the extended approach. I know that that's not great because they get super stiff. The less we do, the better. And because we've only got the 4 choices, we have to make the right one based on the patient, the limb, and the fracture. And I'm a big believer in foot shape first. It's not the joint. I'll say it again. It's not the joint. It's foot shape. Here we've made his joint much better, and you can see how good he is with just a small cut. Less is better. More cuts will lead to way more stiffness. And here's my last slide. And I believe this strongly, is that we need the right doctor, right time. And sometimes not everybody can cowboy up to do all the stuff that's included with giving good fracture care. Thanks.
Well, great presentation, great result on such a terrible fracture for that calcaneus. That's fantastic. I got a question. I'm always confused. You said early versus late doing the small incisions. Any other things that twig you into doing a small incision versus more an extended approach to the heel, like fracture types or soft tissue condition, What other things are factoring into your decision these days? Or can you get most of these now through these small incisions?
So I've been up on the podium with Roy Sanders too many times to count, and he agrees with me. We cannot get that joint perfect through the sinus tarsi approach. Everybody thinks they can. We're not getting them perfect. And your post-op CT will show that. And so I guess what I'm saying, Bill, is that if we're doing them late, just you have to be able to do the full meal deal operation, extended lateral. But if you can get at them early, then less is probably better. And the simple fractures, I think, are way better done through smaller cuts and smaller insults to the foot, because your late and long-term results will depend upon how much surgery you've done. And if you can minimize it, they'll have way better motion, and that's correlated with outcome. The more motion they've got, the better they are. Now, if you got a bunch of blisters, you got a problem. And so that's where sometimes you have to wait. And the full meal deal, right now in my practice, I'm about 50% with the percutaneous reductions. I'm about 10-15% with a full meal deal. And then the other ones, hell, I'm still 25% non-op and maybe 10-15 fusions. So I'm not doing them all percutaneously. I think the full open reduction is for the young person who might be able to withstand a complication in a second operation. But just like we said with the proximal humerus, we want to do one operation and the right one to get the best result.
Great. I think we have Dr. Jamal Al-Asiri with a question, and I'm just wondering if Dr. Muelenkamp will be able to field this question for Dr. Al-Asiri. And just a reminder here that we're kind of at 8 o'clock or a little bit past. If you have to leave, please feel free to do so. We're going to be running a little bit longer, though. If you'd like to stay, you're more than welcome to stay for another case. Sorry, Dr. Al-Asiri.
Sorry, thanks, Dr. Buckley, for a great presentation. And I have two questions, actually. First one, how you obtain all the goals with just wires? I do fix calcaneal fractures. So having like the case that you present with a couple of wires, just lifting the breast fragment, how you maintain your height? Sorry, you get the height. How you maintain the length between the calcaneal tuberosity all the way to the anterior process? Because I find that sometimes actually shortened. That's one. Second thing, your incision, it's not a sinus tarsi, it's not like the horizontal limb of the extensile. It's almost in between subfibular. Is that an extensile approach, or I mean, if you need to extend it, is it something you could extend it or not? Thank you.
Go ahead, Brad.
Yeah, I'm happy to answer. Actually, it's kind of funny. It's nice to see that video, Rick. Those were actually my hands during my fellowship doing the case with you. So I show that case here as well. To answer your question, it's a good question. So the first one, so these are threaded wires, and that's an important point if you're going to be doing these percutaneous. The threaded wires act like rebar and scaffold, and actually are quite capable of holding the length as well as the varus valgus. And it's not just a couple of wires; it needs to be a number of wires in the different planes that you need depending on the fracture. So it works a lot better than you may imagine. I've transitioned largely to using fully threaded screws, either 6.5 or 7.3, which I find gives me a little bit better control. And I don't have the plastrum set up for managing these percutaneous threaded wires in the plastrum, but they do work, and the complication rate, the wound complications are quite low. If you do get a complication with one of them, you can easily just pull them out. So they were very well tolerated. For your second question, that incision is extensile into the sinus tarsi. If you're planning to do it percutaneously, you should be able to manage it with it. But if you were unhappy with your joint reduction, you do want to visualize it, you can extend it into a sinus tarsi and still see it, but you wouldn't want to bail to a lateral extensile.
Perfect. Thanks for that. I think the other Dr. Brad Petrosor may have a question.
No, I just had that was great. And I use a similar incision for MIS stuff too. So I guess what's the tips and tricks for dealing with the lateral wall or dealing with any of that perineal impingement that you want to do? If you really want to go with that small MIS lateral sort of non-sinus, non-extensile kind of approach. That's my question. But that was great. It was a great video. Thank you.
So it's interesting because when you do, lots of reviews, as I do, in any number of journals, you'll see that right now around the world, people have been trying sinus tarsi. They're all fed up with the extended lateral. And these small cuts are happening everywhere because when you finish with your reduction, the best way, and it's pretty well proven now if you're using screws, as Brad has mentioned, is you need something subchondral, which is our standard subchondral screw. You need something that comes from the posterior tuberosity up the length of the calcaneus, and then usually something that comes up underneath the subchondral. So you're actually hitting that calcaneus from all three directions. So when you say, what do you do with your incision? There's lots of different things. You look at each calcaneus, and when you look at it, when I had all those colors, you can see, well, what do you have to do to be able to reduce it? And if you take that laminar spreader all the way across, I'm actually influencing that sustentacular piece that isn't so constant. And you put it back where it belongs, and then everything else falls into place around it. You take the guts of the subtalar joint, which have fallen into the middle because there's always a hole there. You lift it up. Now you can start building it against it. Now that small lateral piece, you can actually take it out. You can just push on it. Hell, I was one of my first calcaneal fractures. I took a mallet and we put him in the lateral position. And I just pounded it until it was in little pieces. And so you just want to narrow the hindfoot, however you do it. And we've learned how to do that, whether it's open or percutaneous.
I just want to make one comment on the pins and how to maintain it, and also just the patients. And I distinctly remember going around as a resident post-op day 1 and 2 on these calc fractures, seeing these patients with Dr. Buckley, their pins are sticking out of their heel by a few inches, and you're there talking to the patient, explaining why their pins are sticking out of their heel and how that's going to help them stay off of their foot. And the whole time we're teaching them how to make donuts with the cling and teaching them how to make these wound care donuts that they're going to make themselves, and it's got them on board and they're all into their fracture. But I think that part of that is, choosing the patient, talking to them, then also scaring the hell out of them so they're not going to walk on.
Because we know that calc patients are some of the most unreliable, non-compliant in all of our practice, and that a lot of people walk in your work. And if you can't make that calcaneus so solid, and of course, one way to keep them off it is you leave those pins hanging out and they don't walk on my work, I tell you.
That's awesome. I think Dr. Muelenkamp has a case as well, and I'm wondering if we should move on to that. I think it's probably going to highlight some even more of these points for this great discussion.
Yeah, it'd be great if Brad, you have time. Hopefully, if people don't mind staying a little late. If you have to leave, totally understand. But thanks if you don't mind. I'll turn it over to Brad.
And yeah, that'd be great. We'll try to keep it brief and the discussion to the point. I'm actually going to have my resident, Dr. Bill Haddon, present the case. He's one of our third-year residents here in Ottawa. He just came off of, I think, about a 4-month tour in trauma and really embraced it and ran with it. So I think he's one of our up-and-coming trauma guys. So I'd like to welcome Bill to share the slides and go through the case with maybe a PGY 3 or 4 who's interested in going through the case with him.
Thanks, Dr. Muelenkamp. Thanks, everybody, for having me here. Thanks, Dr. Muelenkamp, for letting me share one of your cases. Is there a resident colleague out there who might help me out here with this case?
I see I got Dan Axelrod. I see R3 out there.
Hey, guys. I might not actually be able to help because I'm taking care of my son. Apologies. I can try to do it, but I might have to defer once I get started.
No worries. Thanks, Dan. We'll present just a quick, somewhat simple but somewhat complicated common case that hopefully brings out some common decisions that are often tricky to make, especially for someone at my level anyway. So 55-year-old lady with type 2 diabetes. She's obese, hypertensive, has dyslipidemia, OSA requiring CPAP. Steps off a curb and twists her ankle. No other injuries. Presents to a peripheral hospital with these images. These x-rays are text messaged to Ottawa, and a resident has asked for advice. Dan, buddy, could you humor me and just describe the x-rays?
Sure. So AP mortise view and lateral of the right ankle. There's a fibular fracture, the level of the joint, and just above the syndesmosis or Weber B type injury. The fibula looks out to length. There's a bony fleck off of the medial malleolus as well. The overall congruency of the tibio-talar joint looks to be maintained. No evidence of medial clear space widening to my eye. And on the lateral, the tibio-talar alignment looks to be relatively well maintained. I'm not sure if there's a posterior malleolar piece. There looks to be sort of a double, I forget the name of the sign, but there looks to be some double lucency on the AP. So I worry if there's maybe a posterior malleolar fracture.
What would you like next, Dan?
I think I would do. Considering I'm concerned about the posterior mal, I think I would get a CT scan.
So thank you. Excellent answer. That wasn't done. So a stress radiograph was obtained at the peripheral hospital and sent to Ottawa. I'll save you some time here. AP and attempted mortise, redemonstrating what you've already discussed, and perhaps everyone or many people are wondering about the posterior mal and this ghost-like lucency that you can see on the AP. In any case, this patient was sent home in an air cast. Weight bearing is tolerated with 1 week follow-up. So 1 week later, presents to fracture clinic with these images. And Dan, could you please just quickly go through these?
Yeah, so progression of her injury with tibio-talar displacement. The posterior malleolar fracture is more readily visualized. It's, it's not important to say the size, but in this case, I'd say it's about a third of the articular surface.
Yeah.
This patient needs a closed reduction and a good cast.
Excellent. So this is your closed reduction, and McMaster, this is your chance to critique an Ottawa reduction. What would you do?
So these are post-reduction films. I appreciate the opportunity to critique your work, Bill, but I'm not going to take the carrot there. I think in this circumstance, it's an operative injury. So the most important thing is to get the tibia, the talus surface underneath the talus underneath the tibia, and appropriately with appropriate dorsiflexion. I think the cast is adequate. It could have been a bit of more of a varus mold. It could have been achieved to close off that medial clear space, but otherwise I think it's okay.
Yeah, great. I agree. Junior resident was quite worried. Re-reduced, got this. Re-reduced, got this. Same reduction, proceeded to CT scan. So this is perhaps a point of discussion for later about the utility of CT in this situation. These are your CTs. If you want to let it flow for a minute, and then maybe just what you think about the key important features of this CT.
Yeah, so obviously scrutinize it as best I could with my own two eyes before making the operative plan, but it looks like the posterior malleolar fragment is posterior medial. It looks to be relatively large. It looks like the talus is still subluxated underneath the tibia. So I think that would warrant, in my consideration, I think it would warrant open directional fixation. And I can get to the operative plan later if that's interesting to you.
Yeah, that's great. Thanks, Dan. Yeah, great points that you've made. It obviously is still subluxated. There's an incarcerated fragment in the depressed joint fragment. There's also a small AITFL avulsion here. And then a bit of a uncommon or less common posterior medial fragment that involves the posterior colliculus of the medial malleolus. But yeah, great. Okay, so you said this is operative. I think most would agree. What would be your approach?
It's actually interesting. Dr. Johal and I had a similar fracture he managed, and I watched and helped him with about a month ago, maybe 3 weeks ago. And the discussion was made whether or not to put the patient prone for this sort of injury. The difficulty with putting a patient, so in this circumstance, I think I'd put the patient supine with a bumper to the hip and do a supine approach with a posterior medial incision and a lateral incision for the fibula. I would try to get an anatomic reduction of the posterior malleolus first, buttress it up either with with a 1/3 tubular plate or a T-type plate, a cloverleaf plate, whatever I felt was most appropriate for that. And then I would go to the fibula and address it as need be.
Yeah, great. I hope this sparks some discussion too. That's a great answer. Would you reposition the patient? You'd keep them supine the whole time, I assume, and then
yeah, I think I'd keep them supine the whole time. The benefit of going prone is like it's maybe easier to visualize from the posterior medial approach, but then it's obviously difficult to get the fibula to be fixed at that point. So I think I would just go supine.
Yeah, great answer. And lots of considerations. Intentionally presented an obese patient with OSA. So other considerations would be ventilating a potentially anesthetized obese patient with abdominal girth, whether or not you had a Jackson table, whether or not you're going to flip if you started prone. So I think all those things are going through your head too. So, I mean, lots of considerations. We did opt to go prone here. At least to start with posterior medial approach as you've suggested. So just briefly, skin incision just medial to the Achilles tendon, subcutaneous tissues, quite a fast approach really, and then transverse fascia here overlying the neurovascular bundle is incised and tibial nerve is clearly visualized, FHL, clear dissection planes, and usually in the several that I've seen, very quick approach, very easy access between tissue planes, and great fracture visualization. So given this pattern, Dan, I'm sorry I'm asking you all the questions, buddy. What do you think about which fragment you'd address first? Do you have a
Yeah, I don't have enough experience to say that in my hands, I would do this or that. But I think the challenge is that you're sort of seeing from the medial side that posterior colliculus fragment first. And so there's a sort of temptation to fix that first and then build, take 3 pieces, turn it into 2 pieces, and then go further laterally and then take the larger posterior malleolar fragment and attach it there. So I think that's probably what I would do, because I could get my cortical read first off that first fragment. It'd be easier rather than trying to get over the top and reduce it. But I understand the logic of perhaps working through that fragment and then going more laterally and trying to sort of opening the book and fixing it. I think both are feasible.
Yeah, again, a great answer. That's what we did actually. So step 1, using the larger posterior lateral fragment as a door to flap open. We already knew from the CT scan that there's an impacted smaller joint fragment. So opening that door first, as you can see with the dental pick, and then this joint fragment you can visualize clinically and radiographically here was removed. And just like you suggested, the read is the medial fragment first, and then door closing partially on the medial fragment with that posterior lateral fragment. And this is provisional fixation. On the left, you can see actually a nice clinical photo of fracture reduction, 1.6 K wires. And then just like you suggested, Dan, this is 2/4 T-plate posterior lateral fragment. And then there's a quarter tubular 2/7. So that's the posterior mal addressed. What would you do next? Assuming we didn't do your supine plan, would you flip them now?
Yeah, I mean, I don't think I'd necessarily, if you could get to the lateral side easily without having to manipulate it too substantially, like you can then just keep them prone, but I presume that you flip them and then went to the lateral side.
Yeah. So again, good thoughts. And actually that was the initial plan, but reviewing the character of the fibular fracture, long oblique and amenable to PA, interfragmentary compression, we actually left the patient prone. But as you say, it's probably case specific. For her, she was tolerating the surgery well. She was obese. We had good access laterally, so we left her in the prone position. Okay, so then this is definitive fixation everywhere. And then we mentioned earlier there was maybe a small AITFL avulsion. There was also a small fleck off the with a deltoid injury, or at least partial deltoid injury. One last thing you would do to decide whether or not you do more operating.
Yeah, so I mean, once you fixed the posterior malin, you fixed it anatomically, you assume that the syndesmosis is reduced. So you can do stress fuse intraoperatively, you can do a clotting test, and then just check what's going on, see if there's any tailored tilt, if there's any syndesmotic widening. And in this case, it looks like it's nicely aligned. So yeah, probably just leave it.
Awesome. Thank you very much, Dan. Thanks for your help, buddy. Appreciate it. So that's exactly what's done. This is the end.
Thank you for sharing it, Bill.
Okay, so just summary discussion points. So something we can share this mistake and learn from it. Proper assessment of the posterior mal radiographically, especially when you're dealing with remote situations. Make sure there's an adequate lateral. This was missed initially by a combination of people and is a good learning point. Proper reduction is important, and proper reduction is hard to get after a week being mal-reduced. The utility of CT, I assume there's some discussion coming about some would CT and some would not. I'd argue that it was valuable in this case. It helped identify that depressed joint fragment. It also helped us plan our surgical steps, our order of reduction, and our patient positioning. And then which approach to use of the posterior mal? I'm seeing a lot more of this posterior medial approach in Ottawa. And as a junior inexperienced person who doesn't know much yet, it seems very effective to me. But I'd love to hear more experienced voices on that. Then your order of fixation. What do you do first? Where do you stop? Do you reposition intraoperatively? Does the deltoid in this case need fixation? Well, arguably not with a stable syndesmosis after posterior malfixation, just like Dan was saying. And does the AITFL need fixation? Well, probably not with rotational stability of the fibula and the syndesmosis. Thank you, everyone, for listening, and thanks for the invitation. Thanks especially to Dan for helping me out there.
Great. Thanks, Bill, for that presentation of that case. I have a question. If Dr. Adams is still online, just for the U.S. versus Canadian experience. I mean, tonight just it happened to be that all these cases had a delayed presentation or a delayed kind of ability to operate on the patient. I was just wondering if Dr. Adams has a similar experience. We have a large catchment area for a lot of our trauma centers, and being delayed is not necessarily abnormal here, and certainly being delayed on the board. Are you guys finding the same thing at your center or more broadly in the US, if you have any perspective on that?
Yeah, I think that's a great question. And with the pandemic, I think that there's been a heightened sense of, number one, healthcare disparities in terms of people being able to get to medical care or appropriate medical care, and also patients' level of comfort. So patients may present late. So for example, I had a patient that was over 300 pounds and came in with a 4-month-old distal biceps rupture. And I asked him, what was your thought process? And he said, well, I knew the pandemic was happening and I knew you couldn't do anything about it. And so certainly at that point a year ago, we were telling people we can't do elective surgery, and they got the message loud and clear in some cases. And so I can tell you there's a number of patients, because they were afraid to come in to the medical center, delayed care of their fracture, and because resources in some areas were stretched thin, we had a lot of people delayed as well. In the normal course of life in the U.S., we not uncommonly see people delay for many of the same reasons, socioeconomic reasons, lack of resources to get to a medical center. But I think the pandemic certainly heightened that.
Thanks for that. Dr. Buckley, I'm always wondering when I see these posterior mal fractures, if I had that degree of comminution anteriorly, I would almost call this a plafond fracture rather than an ankle fracture. But we tend to call these all ankle fractures. And I think they're bad actors, and they maybe shouldn't fall into the ankle fracture category. But what are your thoughts about that when you see those posterior mals with that degree of impaction? And obviously there was some point loading here on the talus for a delay. But besides that point, looking at that comminution and the impaction, is it fair to call these ankle fractures?
I think it is, because it's a twisting mechanism. That wasn't a loading mechanism. It's just that she was a bit bigger. And so, yeah, I think this is an ankle. But the key for everyone here, the key absolutely is, again, who was looking at the x-rays at the beginning? This is a large joint that was never reduced. It's a great case, Brad. And that posterior mal was there from the beginning. Volkmann was an important German that everyone should know who has anything to do with orthopedics. That is called the Volkmann fragment. And it's been there since forever. And it was never reduced, that ankle. It was out for days and days. And, I look at this and say, it's just a matter of education. We have to educate the eMERGE staff and family docs so they recognize that posterior mal. My own approach is that I like prone. I like to fix the fibula first. I do, because it's an ankle fracture. If it was a pilon, I may not, but this is an ankle. Fix the fibula, and then I like to use just one single approach. I know you can get a little more from the posterior medial side, but from the posterior lateral, you can fix the fibula as well with one incision. And I think we're doing a much better job of these now that we're much more aware. Bill, you're lucky to have a good preceptor who's taking you through all the fine points, but this shouldn't have been missed from the beginning and needed, again, the right doctor, right team, right hospital, right time, right surgery. It's just like what I said with that first case, guys. All of these should have been treated differently from the beginning with more expert eyes.
Yeah, I think those are great points, and I think it's interesting to think of how systems apply to delays and appropriate stick handling, whether you're in a public or private kind of hybrid model. There's just about recognizing where these patients need to go. I think some of those specific points Billy brought up. There's a lot of discussion we can have, and again, totally acknowledge people might need to leave this late, but I think these are great discussion points. Utility of the CT. I mean, we talk about that a lot. If you have a good lateral, potentially you don't need one, but it helps a lot with planning and to tie it into other fractures. Distal radius, we kind of talk about that as well. Similar type of injuries in the upper extremity. Using distal radius, using CTs to help recognize and also plan. I mean, should we just recommend this as a more routine step evaluation for these posterior mals, or not universally yet?
I can tell you, I think where we're going in the future, now that we've had so much video conferencing, is that, can you imagine in a place like Canada, if we set up a video conferencing for the world, and you had China, India, whoever, video conferencing us saying, what do you do with this fracture? And you just had someone on call, and all they did was look at the x-rays. And I mean, you need to see a patient. We all know that. I showed you even my images. But if we had the right doctor making the right decisions early, then even places that were a little underutilized, underserviced, not enough academics doing the right thing at the right time. If you had that video service, God, you'd have much better care. So these sort of things, a plain old simple Volkmann's fragment isn't missed.
Yeah, to that point, having a panel like this, I just think about my own residency. And to have a panel like this, it would have been an academic half day. or, you know, some special event where we would have like flown in Dr. Buckley and everyone else, Dr. Adams, and, you know, locally, hopefully, you know, get these people all to our institution to have this chat. I mean, this is game changing, really. Like, yeah, we have, you know, a panel here that's international with a wealth of experience, and, you know, it's a phone call, you know, basically, and it's great. I think, you know, there is use for that, but at the same time, you know, I agree, we have to be in front of patients and being able to examine them. But just having everyone on the panel here through a phone call tonight is extraordinary, and I hope the residents and appreciate that in terms of training, that this would have been something that would have only happened once or twice a year at your institution, to have such a great panel discuss these cases and walk you through them. So just a great thanks from me to the panel for providing this wealth of knowledge for us tonight, which was fantastic.
I think just you know, to echo all those sentiments, I don't want to keep everybody too long. I think really, you know, those are all excellent points, and I think if we tune into the COTS meeting coming up at COA, we potentially have an opportunity to discuss some things. I know and we've talked about a study where we prospectively just look at a lot of these ankle fractures and try to answer some of these questions, like we've done with Decipher and now Distal Radius with the COTS group. Because, you know, we've done then we heard Dr. Schneider talk about the tightrope study. And you know, although it was a great study, it was still left a lot of questions. And I think RCTs looking at each one of these questions is needed, but it's such a broad complement of injuries that could benefit with maybe a database. So I think, you know, as all of these things can bring up lots of discussion, I think maybe we need to table some of the questions for maybe a COTS meeting coming up and talk about planning a study to answer some of these things. And so with that, I think, you know, if everybody's okay with it, if no burning comments or questions at this time, I'd like to return everybody to the hockey game for the second period is well underway. And thank you, everybody, so much. And thank you to the panelists and the expertise. Thank you for everybody tuning in. And thank you, Bill and Chris, for moderating. It was an excellent discussion, and always a pleasure to connect.
Yeah, great to see everybody. And thanks, Herman, for organizing this. It was a great experience. A lot of fun.
Thank you for bringing.
Recording stopped.
Thanks for including Bill. I think that's it's always great to meet new up and coming trauma keeners in Canada.
Good job, guys. Thanks a lot.
Thank you, guys.
Thank you very much.
This was great.